Hello, namaste. We'll see. I'm Dr. Yogesh Velaskar, consultant physician, having my clinic in Goregaon West. Also, I'm attached to Nanavati Hospital and Hinduja Khar. I will discuss. We'll see about the latest updates in hypertension. So, I'll just see what about the hypertension basically. So, as per the WHO, that is the World Health Organization, nearly 63% of total deaths in India are due to non-communicable diseases, which is a significant amount, of which 27% are attributed to the cerebral cardiovascular disease, which affects 45% people in the 40 to 69 age group. Raised blood pressure is among the most important risk factors for cardiovascular disease. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up, which is extremely important. So in India, the prevalence has also gone up over 30 years to 38% in men and 32% in women, from 29% and 28% respectively. So it has gone up around, say, 10% over a period of 30 years. WHO, despite that, nearly half of the people, or 51% of the men and 41% of women with hypertension, are unaware of the condition. Additionally, over 62% of the men and more than 53% of the women living with hypertension did not get treatment, which is also a significant number. That means people are having disease and they are not aware of it. It is very tragedy. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. International Society of Hypertension has released the ISH 2020 Global Hypertension Practice Guidelines. The inclusion of optimal and essential treatment paradigm attempts to address the issue that in resource-poor settings, optimal care refers to evidence-based standard of care, and whereas essential standards refer to minimum standards of care to allow specification of essential standards of care for low resource settings. The AHA-ACC, that is American College of Cardiology, has released a scientific statement in 2021 offering new guidance for the management of stage 1 hypertension among patients with low ASCVD risk. Among low risk adults, no ASCVD or 10 years CVD risk less than 10% with stage 1 hypertension, that is blood pressure 130 to 139 systolic and diastolic 80 to 89, that is stage 1 hypertension. Management starts with non-pharmacological therapy. If blood pressure remains uncontrolled at 3 to 6 months, consider starting pharmacological therapy. Acute respiratory. So initially, we always used to think that if BP say 140, 150, diastolic 90, 94, it's okay. But that is not okay now, as per the data given above. As per the data I've just told you. Acute respiratory distress syndrome is a potentially fatal condition involving lung damage, and experts often associate it with a severe COVID-19. A recent study which appears in the Journal of American College of Cardiology reports that metoprolol can reduce the lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. Lowering systolic blood pressure targets down to 110 to less than 130 millimeters of mercury range substantially reduce CV adverse events in the STEP randomized trial, affirming that sprint findings for an older in Chinese population. Among some 8,500 patients ages 60 to 80 in China, the intensive target trimmed 26% of the composite CV risk. Findings from now a second major trial supporting a lower target could unite the guidelines, which even among US professional societies range from thresholds of 130 to 150 millimeters of mercury. With regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2019-18 European guidelines on the management of arterial hypertension recommend that the diagnosis of hypertension should not only be dependent on office blood pressure measurement, but also on out of office measurements, such as ABPM or HBPM, that is home blood pressure monitoring, 24 hours, and nighttime blood pressure measurements were associated with a greater risk of mortality and composite CV outcome. Thus, they may be considered as the most relevant measurements for estimating CV risk. For every 20 by 10 millimeters of mercury increment of blood pressure measured at night, the risk of mortality increased by 23% and the risk of cardiovascular events by 36%. So nighttime BP is also very, very important for the cardiovascular events. Most patients with hypertension require lifelong medical therapy to achieve optimal blood pressure control. The 2018 European guidelines equally recommend 5 classes of antihypertensive drugs, considering high non-adherence treatment. The importance of combination treatment is particularly highlighted to improve adherence to the therapy and BP control. Therefore, 2018 European guidelines recommend, especially in the context of lower blood pressure target, to start antihypertensive therapy with an initial dual fixed dose combination of ACE inhibitors or ARB plus calcium channel blockers or diuretic. Since early July 2018, products containing valsartan have been recalled worldwide. The reason is the detection of a known carcinogen, namely NDMA, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by the WHO International Agency for the Research on Cancer to be carcinogenic in humans. If 1 lakh patients would have received NDMA contaminated valsartan from Jianghuai, that is the manufacturing site, every day for 6 years in the highest dose, it could result 22 additional liver cancers over the lifetime of these patients. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they had taken the highest daily dose over 4 years. Valsartan recall accompanied by a significant increase in the rate of emergency department visits by around 6%. The HYGEA study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in the endpoints. The HYGEA chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening hypertension therapy exerts a favorable CV risk reduction. The largest study included a total of 19,000 hypertensive patients. During an average follow-up of 6.3 years, 1,752 participants experienced the primary CV outcome. An ambulatory BP measurement was performed for 48 hours to collect data on how BP differed during sleep. The rate reduction for CV events was significantly improved for nighttime treatment when compared with the awakening treatment. Thank you.